Ready to go.
Shortly. Okay. Is this on? It is on. I just need to look at my notes to see what day it is, and then we'll get started. Thank you. Okay. Just a sec. There it is. Okay, welcome everyone. It's 1:03 on the 17th of July, and I want to welcome everyone to the Pitkin County Board of Health. First, we're going to start with a roll call, and I understand everybody is here. Do you want to rattle off names? Do we need to do that?
We've got everyone here in the room. We've got Linda Vieira and Sam Rose and Greg Postman and Tom Kurt. Online, we've got Barry Ramberg, Krista Giesel, Christine Benedetti, and Liz Stark and Susan Marolt.
Great. Thank you all. Thank you all for being here. I wanted to, first of all, just draw our attention to the minutes from the last meeting. And we could just ask for an approval of the minutes, but I did want to point out there were a couple items that were brought up that were kind of like action items, only just for conversation. And I think, let's see, pardon me for a second. There were a few things on there, or at least a couple that I thought maybe we want to circle back on. They were, and sorry, I'm still getting up to speed here. With who else was here? Ceci Delangelo brought up something last week or last month, and I'm trying to remember exactly what it was, and I apologize.
So she had requested that we do some research around drowning, drowning being one of the leading causes
Thank you.
for youth, and then follow up potentially. I said we could follow up with some educational information, and that if that was of interest in being used to advocate for additional swim lessons at the local rec centers, that is well within board members' ability to do that. So Peter has created a document, and I will send that with the updates from the meeting today.
Great, thank you. I also saw we were talking about bike injuries and helmets, and haven't done any follow up on that, and just wanted to flag that in case you were going to say anything. Additionally, Dr. Kurt asked about op-eds, status of op-eds going forward. Do we want to talk about that now, or is that something that happens later for you?
I've been following up with everyone who volunteered for those op-eds, and in the information that was sent out for this meeting, you can see the July op-ed that Susan authored and was published.
Great, yeah. Thank you, Susan. On bats, rabies, not just bats, but rabies, right? Okay. All right, thanks. That's it. So I was going to look for a motion to approve the minutes, or any corrections if anyone has any.
A motion to approve the minutes.
Seconded. Okay, I have a motion from Linda, second from Tom Kurt. All in favor?
Aye.
Aye. All right, thank you. Okay, next we're going to go to public comment. I know we've got some public comment here. People are here to speak today. Our limit is 3 minutes per speaker, and we keep track of that. Only it's to be fair to everyone. At this time during these public comment, we don't engage with the speaker as much as we hear what they have to say, and that's it for 3 minutes. So it's not a conversation. Just thought I would share that. And then the board may or may not discuss it at some point farther along. With that, who wants to go first? I see a hand in the back. Skippy, come on down. Long time.
Long time. How are you guys?
Great, thanks.
Nice to have things in good hands when you're taking a break. First, it's nice to see everyone. Thank you for your service. I know what this is like, and I know how much work it is. So thank you for everything that you guys are doing. And I think I saw Susan in the digital world. So hi to you. Dr. Kurt reached out and suggested that I come in. So I'm doing that at his request. I recently opened just over a month ago what is the first natural medicine healing center in Aspen, Colorado. We practice psychedelic therapeutic care under the regulated model per the Natural Medicine Health Act. That's something that was put into motion by Prop 122 several years ago, and there has been a board creating a regulatory framework around the safe and responsible, regulated, certified use of psychedelic medicines within a healing container over the last 2 years. I've been fortunate to be on that board, and in fact, I'm jumping off to go be on a board meeting right after this. So I'm really just here to let you know that we exist. The Natural Medicine Act prescribes many things that must be done to operate in a safe fashion. It also provides some latitude as to how psychedelic medicines are practiced and used. Our model focuses very intently on preparation and integration, working with a psychedelic literate, either coach or therapist, depending on the scope of practice, to really focus on healing, growth, and transformation. So that's all that I have. Just is mostly just we exist, and I know this is new for a lot of folks, and there's a lot of, I mean, 6 years ago, I didn't know much about this stuff either, and that's really normal. So I also just want to make myself available to talk to folks one-to-one in groups. I'm actually doing a couple Zooms online. I can send to staff the links just for people in public service roles to kind of start to get familiar with what is or isn't going on. And then I'm also happy to offer my time one-to-one to any of you. I'll leave a card with the website. You can easily book a consultation, and I'm happy to fill in anything that's helpful or talk through anything if questions arise.
Great.
Beautiful.
Thanks, Skippy. Thanks.
Thank
for
you,
coming.
guys.
I'd like to comment first.
Not having a dialogue though, right?
Yes,
Okay.
my
I can't
personal
hear it.
experience is that as a medical toxicologist, I've attended 2 days of a national meeting in Denver that dealt with psychedelics, specifically where research is going on at the University of Colorado Medical Center in Aurora in projects which show a great deal of promise statistically. And I would like to point out that as the Natural Medicine Healing Act exists, the therapist is giving the agent as part of the treatment. They are not dispensing it as a cannabis pharmacy or a pharmacy or an alcohol facility selling alcohol. So it's given as part of the treatment, and it's not a foolish kind of dispensing necessarily that some people might imply.
Thank you. Thanks for that.
Yeah.
Okay, thanks, Skippy. We're going to keep moving.
Okay, beautiful.
All right. Hands up next. Come on down. You have to start with your name, please.
Hi, I'm Martha Himmel. I'm the Executive Director of the Aspen Psychedelic Resource Center. We provide outreach and education around psychedelics to community members, to lawmakers, to anyone who is looking for more information. I understand that you're going to be talking about zoning, and I happened to sit in the meeting, the City Council for City of Boulder, when they amended the zoning. In my public comment that I submitted the minutes from that meeting and the page number. It's like a 400-page document, so it's on page, I think, 314, that describes the reasoning. The law gives suggestions for zoning. It's a baseline zoning, and then allows municipalities to change that. It recommends 1,000. The healing centers are 1,000 feet from preschools, middle schools, and high schools. City of Boulder realized that 1,000 feet from the primary thought process of the law is to prevent diversion, in the same way that you wouldn't want a cannabis dispensary next to a high school. City of Boulder realized that the zoning was such that there wasn't enough space for healing centers to open, so they amended the zoning to 500 feet from middle schools and high schools, and then they removed the zoning requirement for preschools. Here in Aspen, it might make sense to do the same, to allow for more spaces where healing centers can operate, especially around the preschool requirement. What's happening right now is very highly qualified practitioners, a lot of therapists who want to open up a micro healing center in their current office in which they're operating, where the zoning won't allow that to happen. And what's going to happen if we don't amend the zoning is if they can't open up the center, then they're going to be moving their offices out of Pitkin County, which means we're losing therapists. So it's just, I wanted to bring that to the attention of the board.
Thank you.
Yeah.
Thanks for your comment. Okay, do we have anyone else who'd like to come on down? Hello, thanks for coming.
I'm just going to read.
Okay, start with your name if you would.
Ashley Denny.
Hi, Ashley.
Good afternoon. My name is Ashley Denny, and I'm here today to request that the Board of Health advise the Board of County Commissioners to reduce the setback requirement for microhealing centers to 0 feet from daycares at the Aspen Airport Business Center. I was born and raised here in Aspen, and I care deeply about the community's well-being and access to safe, ethical, evidence-based care. I hold a master's degree in integral counseling psychology. I've spent over 15 years working in clinical psychology, specializing in trauma, cancer, chronic illness, and end-of-life care. Work that's rooted in my own experience surviving cancer and losing my mother to a terminal illness. I'm the first and only licensed clinical facilitator in the Roaring Fork Valley. Sorry.
Take a pause. Yeah, it's all right.
Terribly nervous.
Great.
Great, Ashley. I'm the only licensed clinical facilitator in the Roaring Fork Valley and the most trained and credentialed provider of psilocybin-assisted therapy in this region. I serve on the Community Advisory Board for CU Denver's Center for Psychedelic Research, and my work is deeply grounded in safety, ethics, and education. After leaving the Aspen core due to rent increases, I've been quietly operating my clinical psychotherapy practice at the ABC for the last year and a half, including offering sublingual ketamine-assisted therapy without incident, complaint, or my neighbor's awareness. My space functions like a small dental office, serving one client at a time. The purpose of the 1,000-foot setback is to prevent accidental access or diversion of controlled substances, a rule borrowed from liquor and cannabis regulation. But in a licensed microhealing center, diversion is not possible. The state law requires indoor on-site consumption only. Clients may not depart without a chaperone and must remain inside the facility for a mandated length of time depending on the dose consumed. There's no sales. It's highly restricted advertising. Rigorous transportation plans, safety screenings, storage protocols, and video surveillance are all mandated by law. It's important to note this rule is not applied consistently. At the ABC, there's a bar, a liquor store, 2 restaurants serving alcohol, all within 1,000 feet of the very same daycare. Thus, substances with far higher public health and safety risk are permitted, while highly controlled therapeutic use of natural medicine by the most trained provider in the region is restricted. The lawmakers anticipated this issue under Title 44-50-302. Cities and counties have the express authority to reduce or eliminate the 1,000-foot requirement. The city of Boulder has already done so through Ordinance 8665. And here in Aspen, Christina Holloway, the director of Tiny Pines Daycare, across from my office, has written a letter of full support. She understands that true safety comes from training, licensing, and professional ethics, not arbitrary distance. As we know, the ABC is small. The setback functionally prohibits access to legal regulated care, which does not increase public safety. The unintended result is fewer safe providers, increased unregulated use, and forcing me to relocate my practice. Right now, our community needs more mental health expertise and not less. Oregon has seen a 99.87% success rate with safety over 10,000 participants and only 13 adverse events. There's safety in this regulated model. Let's prioritize safety through professionalism, not prohibition. And if you can, please let me know the next step in continuing this conversation. Thank you so much for your time and your thoughtful consideration.
Great. Thanks, Ashley. Thank you for coming in. You did great.
Thank you.
We've also been in receipt of your letters as well.
Yep, and for anyone who wants a printed copy, they've been sent to you via
Great.
email, but feel free to take one there.
Thank you. Thanks for coming. Other public comment? Is there anyone else online or in person? Can we tell if anyone's online who wants in? Let's see a hand up. Is it *9 to raise your hand? Either *6 or *9. I hope I don't get it backwards. I don't see hands up. If somebody did want to,
They can come off mute.
they could come off mute and just tell us and we'll catch up with them. You can have that one.
Go ahead and keep it that so.
Okay, I've got it already. And here's another. He's got one. We're good. Okay, moving on. Okay, I think that's it for public comment. I don't see any more in the room. I'm going to come back to the mental health campaign overview. And Ariel is here. Thank you.
Close to this, do I need to be?
It's the closer the,
Extension.
Okay.
yeah, just point it at you, it'd be better. Bend it down a bit if you need to. And the light's on, red light.
Oh, okay,
Okay,
all right, thank you.
all right, go ahead. Ariel, welcome.
Thank you. I am Ariel Holstein. I am the planning analyst, and I'm going to talk about the mental health awareness campaign that we ran last couple of months. So as I know, or I'm sure all of you are aware, May is Mental Health Awareness Month. And for the last couple of years now, we have launched a media campaign around this topic to raise awareness about mental health. This year was a little bit different. We worked with the agency Kahlo to develop a campaign for the Pitkin County community. Kahlo is a new partner for us. They were selected last year, I believe, as one of 3 media agencies that the county has kind of on retainer, for lack of a better word, for folks in different departments to work with for different media needs. And we selected them, 1, due to their experience with public health, and 2, with their Spanish language capabilities. So we had a few different campaign goals. 1 being increasing trust in the department as a source of information. 2, raising awareness of local mental health resources. If you click on that link, that takes you to a page on the Pitkin County Public Health webpage where we've compiled a lot of those mental health resources along the whole spectrum of mental health care, from prevention to recovery. We took the Board of Health's feedback to have a more positive framing of mental health into account. So people are going to experience mental health challenges throughout their life. Not a big deal. You can access resources, and it doesn't need to be stigma around it. And then finally, we wanted to have some evergreen materials to continue using for campaigns in future years. These campaigns take a lot of work developing the assets, a lot of back and forth with Kahlo to perfect them. So if we have a starting point of materials we like, being able to build on those instead of reinventing the wheel each time. So we had some parameters around our campaign. The total budget was $5,250. $3,250 was from public health, and the community relations team also generously was able to support us with an additional $1,500. And then $3,000 of that went to the design work, and then the rest was for the paid campaign. We shared media through various channels. So the paid campaign was through social media, through Facebook and Instagram. We also did some organic posts as well. And then we had some non-graphics oriented content, including the Aspen Daily News weekly ad. So the first Monday every week in May, we had a little blurb on there with all the Pitkin County information. We had a radio ad on the Tricolor radio station in Spanish. And there was also a blurb in the May employee newsletter. So the timeline, we did plan to deploy the online campaign in May to coincide with the month, Mental Health Awareness Month. We did get a late start and it took a little longer than expected, so that was not on air until June, but all of that non-graphics oriented content was released in May. So essentially it was a 2-month campaign. And we did geofence the ads. So anyone using social media or Facebook and Instagram in Pitkin County and then up and down the Highway 82 corridor would see those ads pop up in English or Spanish, depending on their language preference. So we ended up with 7 assets total, ads. 6 of those were static images. You see 3 of them there. And then we had 1 video, which was essentially a carousel going through all those ads. If you notice the one word in the big font with the different typology and the underline, so in the video that kind of would get written and then erased, and it'd cycle through the slides. I think maybe you all have seen it online. If not, we do have a copy of that. I don't have it linked here, but we do have it. So those are the first 3, and next slide, please. And these are a sample of the Spanish ads. So the English and Spanish were all exactly the same images, just different language. We felt that the images we were able to select could speak to both English and Spanish-speaking communities. Next slide, please. And now for the fun part, for the results. So for the paid campaign on Facebook and Instagram, we had 183,344 impressions. And I just learned about all these like metrics terms for social media, so I'm more than happy to explain them because I don't know if everyone in here knows them. But impressions refers to the total number of times ads were seen. So this is not unique views, this is like total views. So the same people saw multiple ads. The total reach in this is unique views. So 46,165 people saw our campaign. There were just under 2,000 clicks. The click-through rate was 1.09%, and that just refers to of the number of people who saw the ads, what percent of them clicked on them. And then the average cost per click was 66 cents. And then if you break it down further into English and Spanish, so we did allocate 60% of the ads to English and 40% to Spanish, based on feedback from the community relations team, just as more people in the Valley do speak English. So we just put a little bit more resources there. We had 1,300 English clicks, almost 27,000 people reached, almost 108,000 impressions, and then a 70 cents cost per click for English. In Spanish, we had 692 clicks, a little over 19,000 people reached, about 75,000 impressions, and then an average or a cost per click of 58 cents. And in comparison, for our organic social media post total reach, we reached 1,203 people, or 213 people. So you can see that implementing a paid media strategy led to 38 times more people reached. So relatively cost effective, not a super expensive campaign. Additionally, we had 2,555 post engagements, so like likes, shares, comments, and then over 3,000 new social media followers. That was between the 2 accounts on Facebook and Instagram. So we did reach a lot of people and they're not following us. And I've just included some of the comments that people left on the assets. Kindness and empathy have no borders. This is a great initiative. Sharing this, we're lucky to have local help. How can I talk to someone directly? Being able to get support for addiction in the family makes a difference. And then in Spanish, it would be good to mention the available resources in Spanish. Next slide. So based on the results, Callow came up with some next steps for us for next year to continue making our campaign better. So we talked about modifying the assets, one of those being tailoring them to more specific populations. So this go around, we weren't really able to get more specific than just English and Spanish speaking because we had a relatively small budget and we were working on a tight timeline. But we hope to eventually have ads that appeal more to older adults, to youth, and to the LGBTQ plus population through combination of imagery and the language used. We talked about utilizing our most successful assets to then inspire modifications to those in new assets. So one finding from the campaign was that those videos were the most popular assets we had. People really liked that. And then a couple of the static images were more popular than the others. I forgot to write that down, but they weren't all equally performing. And we also talked about doing A/B testing to optimize creative over longer campaigns. So what that means essentially is having like two versions of the same asset and seeing which one does better, and then keeping the one that does well and changing the other one or getting rid of it completely, and keep kind of going through this iterative process to get better and better ads for more and more engagement. And that works over kind of a longer time period. We also next time can create conversion tracking to measure links and resource usage. So this just refers to more of the back end stuff. We didn't have everything completely set up to be able to get like really good data on who was engaging with the ads, but with everything set up on the back end, you can learn more about people's age, their location, and just more demographic information to help target those further. And then finally, developing further iterations for future performance. One recommendation from Kahlo was using user-generated content. So basically working with people in the community, whether that's to have their face on there, to have like a brief video of them sharing their story, just like that authentic content. I'm not sure if you all are familiar with the Community Compass campaign, but they have some great videos of people telling their stories around substance use. So like thinking kind of along those lines. Do you all have any questions for me?
Questions, comments? I'll look online, or people can chime in if they want to add something from.
First, I'd like to comment, congratulations on doing a superb report, and your response of 3,500, especially with a good proportion from the Hispanic or Spanish population, is really great. So that see what you can enhance in doing that for May next year. I know Kayla Bailey from the school reaches a lot of people, and we've both been at some of her presentations, and working that in would be interesting too. So thank you for a great report.
Thank you.
Thoughts?
Uh,
Sam?
I was just gonna ask, do you work with headquarters on stuff like this, or is this separate from them?
So this was not in partnership with headquarters. I have worked with them on other projects, but not this one specifically. Last year, I'm not sure if you all are familiar with our mental health campaign. We did it a little bit differently, where each week in May a partner was featured, and they were one of the partners. But I was not involved in that project, so I can't speak like in depth to how that went.
Okay, just curious.
Kim?
Question. So I was just looking at the ads, and can you just take me through, because I'm not very well social media oriented. So these ads were up in where?
Facebook and Instagram.
They were on Instagram.
Yes.
Okay. And so if somebody looked at these and said, yeah, I want this resource from this, where would they go?
So in the caption.
In the caption?
So Instagram is kind of annoying. You can't, like if you write a link, you can't click on it.
Yeah.
We did create a short link. So in English, it was pitkinmentalhealth.com, and in Spanish, saludmentalpitkin.com. Similar to the PC Health News, but we didn't want to divert the PC Health News, which I believe is still on measles. So we created a different link so folks could hear it or just like see it written and not have to type in a random link. Because if you actually click on it, it's not an easy link to just get to.
But there is a link that takes you to the
Yes.
Pitkin County Public Health website.
Yes, it goes specifically. So I linked, I think on the first or second slide, a page of compiled resource that link takes you there.
Okay, I'm on the website here. I'm just for next year. So this is what comes up.
So if you go to
Is that right?
No, it's
Okay.
pitkinmentalhealth.com,
Okay.
and then it'll redirect to the actual link.
Because it looks really cumbersome to me. Like if I were anyone, I'd be like, I have no idea where to go. So it's pretty clear, like who the
Mhm.
options are to call from that.
Yeah,
Okay.
it's in the captions, which I didn't include the captions on this
Gotcha.
message just now.
Okay,
Yeah.
thank you for explaining that.
No problem.
Any other comments, questions? If you give me a quick overview on, the point of this was to determine if you could create a media campaign that would actually get eyeballs on it, right?
Yes.
That was the objective, and the key result came. So what you've delivered. So this is pretty much done,
Yes.
but you're going to do it next year, but only in May, or are we thinking of doing this ongoing? What's the final outcome we're aiming for here? Because it seems like a great experiment, but I'm not sure where it's going.
We've been doing a mental health campaign every year for the past once a year for the past several years. And so I think that the intention is to continue to have campaigns that public health does throughout the year. We've done some similar themes over the years so that folks in the community can kind of start to remember it year after year. As Ariel said, we invested in developing some content. So the idea is that we would do this again in May of next year. And we have brought the topics of those campaigns to the board at the beginning, either at the end of the year or the beginning of the year, so the board can see and weigh in on those topics that will be covered throughout the year.
Right. I'm trying to think of, the way that when they established 911, the whole point was it was the first thing that came to mind if you had any sort of emergency. If there's any confusion at all about how to get, it's great to have the campaign. It's great to have it in your head, and that's the whole point of it. As long as we know that any time of the year, not just in May, it'll be available and accessible to people. And, do you think is it as easy enough and is access to it easy enough, like just knowing to call 911 if you have a problem? Is that the message that will come through, or do you have to go in on the website and look around for things? Because Kim makes a good point.
You have to look around for things. I'm just searching on it right now. I hadn't really looked at it. And there was one, we got to two different ones, but this one where it's, Jordana just showed me. So if somebody's in real crisis and they're just like, I just need the number, they're not gonna have a clear vision. I'm just thinking what comes to mind. So real person support, and it shows right here, phone numbers to call, but this is a Colorado wide, not a local, right? The 844-493.
So that one I believe is the crisis line, but there's a whole list of local resources and
Right.
the short link. So like instead of typing in, the link in your browser, it's like Pitkin County / some numbers, hashtag, whatever, but pitkinmentalhealth.com takes you right to that page. And that's in the radio ad, that's in like the captions of the
And just
So
thinking
is that-
about
social
it,
media.
it sounds like we can't just use one organ, like we can't just say call the Hope Center, right? Because there's all these other ones, so you can't just have there's no like 911.
Yeah, so it's
And the idea is to share all of the vast mental health resources that do
Right.
exist.
Yeah.
And so we're not trying to be 911, but this is not where you go in an emergency. There is a separate whole crisis campaign for that. But our thinking is that continuing to promote these resources year after year will help people know that they can come here, that there are some of these resources, what the options are. But we can do a better job of, if folks do somehow get to just our homepage, making that easier to find right from the homepage. We've got some rotating buttons and can consider making mental health resources one of those.
And I guess if there's, do you have here anywhere, if you feel suicidal, call 911?
Well,
or you're not
yeah.
addressing that?
Yes, so there's crisis
Right.
services in there as well,
Okay.
right there first off.
Right. Thank you. Well, thanks for paying attention to all that and for sharing this.
yeah, thank you.
Great
It looks like it worked.
initiative, yeah.
Did well.
Okay, I guess we're ready to move on. Is that it? Thanks, Ariel. Thanks for
you.
coming in. Are we up for the epidemiology update already, Carly?
I hope so.
Come on down. You're here.
Nice to see you.
I wasn't sure if there's any other mental health issue thing on there, so we're good. Thank you. Go ahead.
Thanks for having me back. Want to kick off with kind of our go-to subject that we always love talking about, and that is going to be kind of our respiratory season. And in particular right now, since we are officially out of our routine respiratory illness season with flu and RSV, we are, as ever, looking at COVID-19. In all honesty, there is nothing shocking going on with COVID-19 right now. This is becoming fairly routine. We're starting to see increase in wastewater data showing that there's likely increased rates of COVID-19 locally. This is also happening nationally. This is what we've seen for the last few years, is this kind of midsummer push in cases, especially associated with our tourism. I do want to highlight that there is very little genomic surveillance going on at this point. We're not getting explicit samples sent in for sequencing, so it's incredibly difficult to pull out what symptoms are associated specifically with what variants. So even though we might get a little bit of data knowing in what regions or what wastewater sheds have certain variants, doesn't mean that we can explicitly say much about what types of symptoms we're seeing. So just want to highlight that, is that the way that we're interpreting a lot of this data is changing. And so what is beneficial though is that we are still getting hospital metrics, meaning that we are getting severity indicators. And fortunately for us, this current variant that seems to be increasing at a very rapid rate, that NB.1.8.1, Jesus, so quite the mouthful, is not charging ahead in severity. So are we seeing an increase? Yes. Is this shocking? No. And that some of our data is changing in what we're looking at. The best thing to take away from a lot of this is, as ever, our healthy best practices. Certain individuals, especially 65 and older, or potentially suffering from other pre-existing conditions, making them high risk, may be eligible for an additional vaccine currently if they are interested. Washing your hands frequently, great way to prevent getting ill with many things. Staying home if you are sick not only increases the rate at which you recover, but also protects those around you, and masking when appropriate. So being aware for many reasons at this stage, masking during travel, in planes, trains, buses, avoiding any crowded indoor areas, especially if you potentially suffer from higher risk of COVID. All excellent practices to help keep yourself safe and well this summer. And that's COVID.
And a quick shout out to Carly for being so great to respond to all of our local media requests. There was an article in Monday's paper, much to the same effect. So thank you.
Other comments or questions?
Is the vaccine that's coming out in September, it's different than what's out right now, right? I just spoke to a pharmacist
You
about
know, we
that.
don't know, and that is an excellent segue into our next space. You really kind of jumped the gun there. So I don't know yet. Hopefully is going to be my answer. And why we don't know is due to the ACIP changes and possible update and differences in what this incoming respiratory illness season may look like. So the ACIP, this is straight from the headlines. This occurred last month, 2 months ago now, excuse me. So in June, the HHS did remove all 17 members of the Advisory Committee for Immunization Practices. Just to sort of reiterate what this committee does, is that the FDA grants approval for incoming vaccines. They judge and weigh efficacy versus safety, and determine what is safe and ethical to use, effective to use, excuse me. This then gets sent to the ACIP. ACIP has, for the last 60 odd years, been the nonpartisan experts from various and very diverse fields, making recommendations on which vaccines are not only safe, but also which groups of individuals in the American population these vaccines are approved for and most beneficial for. This has, again, been consistently nonpartisan. This has been consistently data-driven. The ACIP has really led the world kind of in vaccine policy. And then from this, the ACIP offers their recommendations and the CDC director then signs off. Based on the ACIP recommendations really dictates who gets the vaccine, when they get it, how they get it, et cetera, et cetera. Not only there are some further downstream complications and implications, such as which vaccines insurers are going to cover. And so this has been sort of the setup for decades at this point. The entire ousting of the entire board has never happened. This is new. And the very rapid replacement of it was 8 people, 1 person stepped down. These 7 individuals who make up the new ACIP have conflicts of interest. They have not been fully vetted, or at least vetted to the same level that the prior members had been, especially for conflict of interest. And their backgrounds are a little more dubious. Many have associations with organizations that are spreading misinformation, particularly around mRNA vaccines, like our COVID-19 ones. So there is a lot of concern around these individuals, as well as the effects that this will have on vaccine policy going forward. They did meet late last month, June 25th through 26th. This is the meeting that typically we hear about flu vaccines, we hear about the RSV vaccines, and we hear the recommendations, the voted on recommendations for COVID-19 vaccines. So flu vaccines were approved, which is fantastic. The only impact is to thimerosal. This typically is a additive to multi-dose vials. That's roughly 7% of the entire flu kind of supply. I don't want to say that's negligible. It isn't. 7% can make or break a flu vaccine, especially in seasons that are severe. And a lot of those multi-dose vials go to help support larger scale, lower income vaccine groups. So individuals who are doing multiple vaccines in pretty rapid succession. And that is kind of a shame. I do want to highlight that this was not a choice made on any presented data, any presented science. It was kind of a curveball that they brought this up. And so do want to highlight that this is a dramatic deviation from prior activities done by the ACIP. A few changes were made to the RSV recommendations. This is also kind of a curveball. I am very happy with this. RSV is going to be available in very similar ways that it has been for the last season. That is amazing. That is great. That can go a really long way at protecting a lot of our most vulnerable populations. And then the really big one is that they did not vote on COVID-19. Why they typically do this in June is this allows manufacturers to update those vaccines. It allows them to gauge how much vaccine to make. It allows insurance companies to update their coverage policies, and it allows providers to go through with pre-ordering, especially for high risk and vulnerable populations. Because they did not vote, nobody knows what's happening. And so will there be a vaccine available? I don't know. What will that look like? I don't know. And who will be able to get it? I do not know. And so this is a massive change. And just to highlight the next time that the meeting is set to come together, or the ACIP has come together, usually they have these meetings set well in advance. There is a very big public comment period. The agendas are made public. They have not even set the date. We do not have an agenda. We do not know what they will talk about. And that is in August and September, or September. And so at that point, we should be functionally, especially if it pushes into September, we should already be administering COVID vaccines. And so it is not looking great. And this isn't just COVID. So I do want to highlight, of course, this is what we're looking at already kind of pre-planning for this incoming respiratory season. But these changes in ACIP could dramatically change how all vaccines are administered or developed. So.
Great. Anything else? Dr. Kurt?
Thank you for that wonderful report. From the practical standpoint, vaccines usually come out for the fall season at the end of August, early September. And because we meet in October, you might consider putting out some kind of a public health announcement of the vaccines that are available and released at the time they're released to encourage, residents to proceed instead of waiting till October. Now, the question is then, will the Nimbus or NB181 be in the COVID vaccine? I presume that it will. And the question is then, because if the COVID immunity, either from getting COVID itself or from the vaccine, does not last that long, should you really get the COVID vaccine a second time? That's what I'm thinking. Like if you were get it in September, get it again in January or February, if you really want to be properly immunized and prepared.
I think the
So,
recommendation was if you got it in early enough to get it again, especially people at risk.
Yeah.
Elderly people. Yeah.
So that interim period before we meet next, I would encourage you and Jordana to consider some kind of a public announcement of what's available. And signed by Kim, what the public is advised to do at that point.
And it will be very tricky because that recommendation from the FDA and the CDC is changing and in conflict right now. So the FDA recommends one thing, the CDC recommends another. And so where do we find ourselves and how do we navigate that? And that is going to be an ongoing complication, I see.
Are you talking about all vaccines or just COVID you're talking about?
Well, vaccines, are first approved by the FDA and then the so-called ACIP committee, Advisory Committee on Immunization Practices. The CDC usually just stamps it in the next week or two.
Nation to,
Yeah.
is it just for COVID that you're talking about?
That was my understanding, that it was just COVID.
Mhm. And we are hoping in the broader picture, we are hoping to also do better or further and continue our communications around all respiratory illness available vaccines. The COVID-19 one, of course, we don't want to confuse the public by making a recommendation 1 month and then having to backtrack the second.
Mhm.
And so I appreciate the recommendation in the sense of we don't know what's happening. If you want to go get it. But I do think making sure that we as public health maintain that level of trust and try not to whiplash our messaging. And unfortunately, this is just going to be confusing.
Maybe an op-ed by you in September.
I'll take it to note.
Great, thank you for that. Anything else?
The most concerning thing about this, as you mentioned, is insurance coverage. And that's what people rely on, and how much, if it's not formally recommended, but you still want one,
Yep.
that's the concerning part.
Yep, that's a lot out of pocket.
I imagine a lot of people will not be getting it if it's not covered by insurance. Hopefully they pull through.
Yep, fingers crossed. Keeping it interesting.
Carlin, can you hear me? This is Liz.
Yeah,
Hi.
Liz?
Hi, Carly, I have a question. Are you expecting that our pharmacies and community health services will even be receiving vaccine in August, as we typically do?
I can't expect anything. That is one of the hiccups here is, right, that pre-ordering for providers and pharmacies without that ACIP approval or recommendation, the CDC cannot sign off, manufacturers cannot ship. And so I don't know.
Okay.
But it is a possible that no, it is possible that we do not have a COVID vaccine this season.
Excuse me, they do have the old vaccine though.
Yes, right
Yeah.
now.
Mhm.
Yes. And hence the confusion in messaging. And I get it. It is complicated and it is frustrating. So trying to convince. Yeah. Yeah, I get you. Hopefully some good news here. So good bad news. Bad news with the silver lining. The USA has passed officially the 30-year record for measles cases. So we are technically over this at this point since I've made the slide. I think we're kissing 1,300 right now. But fortunately, we are seeing a decline in the increase in case rates, and that is due to the West Texas outbreak slowing down and kind of coming to a halt, which is fantastic news. So that really large increase in cases out of that outbreak is no longer contributing to the increase in cases. That being said, we are seeing ongoing spread of measles throughout the country. A good portion are due to travel, so individuals who are traveling abroad, contracting measles there, and then coming home and maybe infecting a small number of people. And that current kind of metrics from CDPHE are showing that we can expect to continue to see a rise in measles cases over the next 4 months. So that is actually a decline. So in the height or right at the tail end of that outbreak, CDPHE was anticipating 6 to 9 months of ongoing measles transmission. So they have thus adjusted, and we are now looking at a shorter time frame, which is good news. That's our silver lining. Pitkin County is not immune. We have done some rule out testing, especially with our increased travel. Not only do our resident populations travel, thus making themselves fairly susceptible to measles, but we also accept a bunch of travelers who might be carrying measles and who are of unknown vaccination status. And so we are on high alert. Carlin Porter, who is not here today, has been working really, really diligently on a very specific measles response plan should we have a case locally. This includes notifications, public outreach, as well as vaccination efforts for that kind of rule out vaccine and response vaccine, which is great. And that we do have a relatively high vaccination rate in the county. So I don't want to say we're immune. We're never immune. But we are in a fairly good space between all the efforts made locally, but for our medical providers, Aspen Valley Hospital, all the vaccinations that Community Health Services is doing, we're feeling fairly good about our space with measles, even though we are on high alert. Another silver lining for our Colorado wastewater initiative, let me just bumble through that, is that we are able to detect measles in our wastewater. This has been an ongoing project. One of the major difficulties is that that measles can be detected from the MMR vaccine in wastewater. And so can we differentiate a true spread of measles, somebody sick with measles versus individuals receiving that MMR vaccine? And we can, which is great. And so this is not publicly available information just because there's not enough data to be able to say much around caseloads or anything like that. But that if our wastewater were to be detected with a actual true case of measles, we would be notified by CDPHE. This can hypothetically act as kind of an early alert system, especially if a traveler was in county and maybe not isn't a resident, but might have shed that virus while locally. And so this is just one excellent case study in why that wastewater continues to be a really dynamic tool for our disease investigations. So a little bad news with really high measles cases, really good news. We have some neat tools and are feeling pretty confident about our ability to respond.
Could I ask a question? Any other questions first? Anyone else want to comment on? Just regarding measles, history of measles, it's the 30-year record. How is it actually compared to previous years? Is it something that has been slowly increasing to get to this point, or is this an anomaly caused by changes in policy, or how do you characterize what we're seeing with measles?
Right now, so measles is really the trend of measles is really the MMR vaccine was introduced and the death rate and case rate due to measles plummeted over the course of 5 years from being one of the largest and killers of children in the United States to functionally being eradicated, to being declared eradicated in the United States. The reason over the last 30 years, let's look at kind of what we saw 30 years ago to what we're seeing now. There was a really large outbreak, a singular outbreak, kind of relatively similar to this, really large outbreak that led to that massive spike in cases in I'm going to get my dates wrong because I haven't looked at it. What's 30 years ago?
19 something.
exactly. Thank you. 2015, 2014, if I remember correctly. Nope, that's not it.
No,
2095
maybe?
1995, my gosh. And so 30 years ago, very large outbreak of an isolated population. And so it was very limited to that group. That was a population that had low vaccination rates, similar to what we saw occurring in West Texas. What is a little bit different about this epi curve is that we're not just seeing one singular spike, right? We do kind of have a true epi curve here, is that due to decrease in MMR vaccination rates across the country, we are seeing much wider spread isolated cases with limited spread in those communities. So not just within one population, but then we are seeing it sort of web out. And so there is increased susceptibility. The MMR vaccination rate across the country continues to decline. We are really fortunate. Our local school nurses and pediatricians have done a fantastic job at outreaching. We've actually seen a slight increase in MMR vaccination rates, especially last year. And so nationally, though, there is increased risk, but it's functionally zero until we have an event like this that really starts branching out across those susceptible populations.
Right, thank you for that. Appreciate it. Should we move on to TB?
Totally keep it interesting. So just want to highlight that on top of all the other lovely respiratory illnesses that we're seeing circulating, tuberculosis activity continues to increase. And so do want to call out briefly that there is a difference between latent TB infection and active TB disease. And so many individuals who are exposed to tuberculosis, whether that be through kind of living in a country where it is endemic or coming into contact with an individual who is suffering from active TB disease, will suffer latent TB infection. They are not sick, they are not ill, they are not transmitting this, but that bacteria is living within them. And 1 in 10 of these latent TB cases will convert into active TB disease, thus becoming contagious. And so latent TB infection is not mandatory to report, it is not mandatory to treat, but one of the best ways to prevent conversion into active TB disease is to treat latent TB disease. Active TB disease, on the flip side, is most people here, I'm talking to the choir, is an active respiratory illness. It can lead to death if not treated, and can be really devastating to populations. TB is globally one of the leading killers of human beings. And so active TB disease is very, very common kind of outside of the United States, but within the United States, we don't see it that often. Do want to highlight that in Colorado, we are seeing an increase in not only latent TB cases, but also active TB cases. There has been a 30% increase over kind of after a 10-year decline. And so the most recent data that we have is from 2023, anecdotally, and kind of what we're looking at out of 2024 is that increase has just continued. And so do want to highlight that Colorado is experiencing an increase in active TB cases and an increase of LTBI. We are not removed from this. Pitkin County, I've done more TB work in the last 2 years.
I have a question of Kurt, because in the past, food handlers were required to have a TB skin test before they went to work. What is the, with this going on, what do you advise?
Come on down, Kurt.
Tag team.
Dr. Kurt, that one caught me off guard. But I'm not familiar, we used to do the retail food inspection program in the state. And when we did that, I'm not familiar that there was a requirement for TB testing within that regulation. So I'm not sure if it still is required now. It certainly hasn't been since I've seen it, unless it's in a different set of regulations that we don't enforce.
And I know for immigration, TB testing is required. But that skin test, the TST test versus what we are seeing a lot of is the blood tests, which are typically more reliable, more sensitive, more specific, is required for immigration. But because latent TB infection is not required to be reported, we do not see all those cases. So we would not know who's getting tested. And especially with the skin test, that really is dependent on the individual medical provider to go through and report those. And again, if it's latent, so they're not suffering illness, they're not symptomatic, they are not sick, we will not see those. So it's hard for us to kind of get a handle on those skin tests.
Can I ask, do we have any idea, do people who have TB know they have it? I mean, or latent TB, do we have any metrics on that? Do people even?
Because it's not reportable,
So,
we have no, I hate to say we have no handle on latent TB infections, but it's not required for providers to tell us. It's not not required for providers to treat it. And so ideally, yes, there is some level of communication going on between medical providers and individuals suffering with latent infections around treatment. And that hopefully that language is strong enough to say, you are not sick now, but you don't know what's going to happen in 10 years. If you have food insecurity, if you lose your housing, if you get co-infected with another respiratory illness, maybe it's COVID, maybe it's flu, this could convert fairly easily. And so all of these factors go into that conversion rate. It's not just you're young and 20 and fine right now. What does that look like when you're 30? What does that look like if you develop cancer, if you contract HIV? There's this life of possibilities that make individuals susceptible to that conversion. And so even though providers are looking at a young, healthy, hypothetically, young, healthy individual right now, taking into account some of those unknowns and moving forward with treatment for latent infection is a heck of a lot easier and simpler than treating active TB, and obviously better for public health.
thank you. Can I ask just the last bullet point, work-associated food availability? Is that food insecurity or is that?
So it's a lot of, so within Pitkin County, we don't have to run through all of these. This is a very wordy slide. But within Pitkin County, our risk factors are predominantly with our travelers and our seasonal workers, and so or our import of workers from elsewhere. We have a lot of international workers that make up our wonderfully diverse community. These individuals sometimes get work associated food support. So hypothetically, you work in a restaurant, you work in hospitality, you're working in a hotel. A lot of these spaces have work attached food resources. And so you're getting a family meal, you're getting a cafeteria meal served through these major hotels. That's job associated. If you're off season or if you aren't working for whatever reason, and thus your calorie intake halves hypothetically, that reduction in nutrition can dramatically impact TB's ability to convert into active infection. And so from many countries, individuals can be exposed through to TB. So we have likely high rates of latent TB infection that is not getting treated. And as this sort of either food instability, housing instability, workplace instability occurs, this can increase the rate or risk of conversion into active TB.
Great, thank you for that. I know we're.
Actually, interestingly, the other thing we've noticed with the short-term housing, a lot of those do not include kitchenettes or any type of full kitchen. So if they're not getting a full meal and they're, especially here in off season, they aren't necessarily provided a way to even prepare meals for themselves easily, which it's come across. We've had several cases where that has come up lately across various diseases where we've noticed that. So,
yeah. And I do just want to do a quick little shout out to our contractor, Community Health Services. Liz, I know you're on there. But Community Health Services is our contractor for a bulk of the tuberculosis work, especially when it comes to testing, chest x-rays, case management, the whole kit and caboodle treatment. They are essential in working these cases, and these are incredibly complex and incredibly detailed and intensive investigations applications and cases to manage. There's oftentimes language barriers that have to be navigated. There's oftentimes secondary support that needs to be provided. These are also working individuals managing how to get them daily treatment, daily observed treatment, while they're also working a shift is incredibly challenging. And the amount of compassion and the thoroughness in which community health services completes this work, even under a contract that doesn't fully cover every piece of this project, is incredible. And so kudos to everyone at CHS.
Great. Thanks for that call out. That's great. We should do that more often. Thanks, Liz, and everyone else over there. Okay, we better keep moving. Okay, on to the next event. Thanks for coming.
Okay, so the Board of County Commissioners has requested that the Board of Health provide a recommendation back to them on what would be the recommended distance between schools and childcare centers, between psychedelic healing centers or other natural medicine businesses. So before we get into discussion and recommendations, we've just got a couple slides to give some background. So natural medicine in Colorado, as was stated by some folks giving public comment, Colorado legalized psilocybin mushrooms for personal use or use by healing when the governor signed SB 23-290 into law. That happened in May of 2023. There are a variety of different state departments that do play a role in regulating this program. So within the Department of Revenue, the DOR, they're responsible for licensing and regulating natural medicine businesses. So the healing centers, cultivations where they're growing it, manufacturers, if they're creating any kind of product from the raw material, and then testing facilities, as well as their owners and employees. The Department of Regulatory Agencies, DORA, licenses and regulates the facilitators of natural medicine. And then separately, Colorado Department of Public Health and Environment, CDPHE, is responsible for natural medicine testing, facility inspection, and certification. So that is all happening at the state level. The distance requirements are what is outlined within the Colorado Regulated Natural Medicine Rules. And so those require any natural medicine business to be at least 1,000 feet from a licensed child care facility or school. The definition of a natural medicine business, it can include a healing center, a natural medicine cultivation facility, a natural medicine products manufacturer, or a natural medicine testing facility. So those are all included right now in that 1,000-foot requirement. The next slide, I'm going to turn it over to Dr. Levin to talk a little bit
I just have a few slides. So we thought that this would be interesting since this is a brave new world, and the only other state that has done this is Oregon, just to look at other legalized substances and see what has been done with that. So looking into tobacco and nicotine, it's 500 feet from a school, and that was in House Bill in 2020, and also increased the minimum age from 18 to 21. It does not specifically include daycare or childcare centers in the definition of school. Looking at alcohol, it's also 500 feet from a school. That's from the Colorado Liquor Code, which apparently is very old, I think 1940s, and it keeps getting updated. So 2018 update included beer as well, includes K through 12 schools, again, does not include daycare or childcare centers by definition. And then marijuana, which was more recent, 2019, all licensed retail and medical marijuana stores include K through 12, and it's so they made it stricter, 1,000 feet from all schools. So K through 12 and childcare facilities, public or private, and then they measure it from a straight line from property line to building entrance. All three of these, my understanding in Colorado, that local jurisdictions can make changes on them. So if they want to make it more or less restrictive. In Oregon, which I thought would be interesting to look at as well, so their 2020 statewide policy for psilocybin, which is what we're talking about now, and it's the only other state that has legalized psilocybin, they put it as 1,000-foot school buffer zone, so straight property line to property line. These are the reasons that were cited: youth protection, neighborhood compatibility, regulatory consistency with marijuana. They have 1,000 foot for marijuana as well. They said in Oregon that a local government jurisdiction can restrict it further, so they can increase the distance, but they're not allowed to reduce the distance in the state of Oregon. There is in this as well. So really it looks differently from schools and daycare / preschools. So they do not have any regulation specifically on daycare / preschools. All of this is just for schools. Next slide. There's a lot of studies looking at this. And so driving public health policy typically looks at studies and tries to get, okay, where did this 1,000 feet come from? And there's a lot of studies. I thought I would just cite one just to take a look at it: the effect of tobacco outlet density and proximity on smoking cessation in American Journal of Public Health in 2011. So they looked at, and this is how these studies look at this. So participants living in a short walking distance, they chose 500 meters, which is 1,500 feet, of the closest tobacco retail outlet, were less likely to maintain continuous abstinence from smoking 6 months following a quit attempt than those who lived further from the closest tobacco retail outlet. So the strength of relationship increased with a decreased distance. So the shorter the distance, the more likely they started smoking again. And the longer the distance, the less likely people started smoking again after a quit attempt. So residential proximity, and these are kind of obvious things. So it's readily available, there's cues for smoking, the advertising for smoking, and all of this type of exposure that exposes people to want to do it again. So exerting greater control over locations of tobacco outlets through zoning regulations may reduce access to cigarettes, ultimately decreasing smoking prevalence. And so kind of using this as one substance, applying it to another, we don't have a lot of data on psilocybin at all, especially since it's not legal on a national level. So I just thought I'd bring this up, and as like these are studies that drive public policy for legalized substances. So next slide. And so this is the reasoning behind zoning distance. So protecting youth from exposure and influence, discouraging underage use, reducing foot traffic, encouraging family-friendly learning center environments, school buffer zones, creating consistency with state policy to create drug-free zones, maintaining public confidence and equity across all socioeconomic neighborhoods, which I think is really interesting, important as well. From a physician point of view, the American Academy of Pediatrics strongly advocates for policies that restrict tobacco and alcohol access to minors, including those related to school zoning. So public policy and public health approaches, I think, are critical to protecting youth from underage exposure and use of substances. That being said, it does look like the public policy so far, we don't have a lot to work on. We can look at Oregon, and Jordana is going to talk a little more about some of the changes that have been made locally in Colorado on this. But there is a distinction, there seems to be a distinction between schools and preschools / childcare centers.
Okay.
So next slide.
So I did some digging. The state wasn't able to provide me a comprehensive list of all local legislation that's been made to date that has to do with this. As I stated, it really lies with local municipalities and jurisdictions as a part of land use code. So this is accurate as to what I was able to find. So at this point, those jurisdictions that are consistent with the state with that at least 1,000 foot requirement from schools and childcares include Aspen, Basalt, Snowmass Village, Eagle, and Garfield County. What Dr. Levin was stating, there were two changes, two local jurisdictions who did make changes with regards to this distance. One was referenced earlier in public comment with the city of Boulder, changing the requirement to at least 500 feet from any middle, junior, or high school, which means having no distance requirement for elementary school or child care centers. And then Colorado Springs went in the other direction, and they increased the distance to at least 1 mile from school, daycare, or drug treatment centers. So they increased the distance and increased one factor of including drug treatment centers as something that needed to be considered. So that is all the information that we have to present to you. As Dr. Levin shared, Colorado is on the leading edge here of creating policy and learning. And so with that, we're really going to open it up to Board of Health discussion with the ultimate goal of being able to have a unified recommendation to the Board of County Commissioners as to what they should consider for those zoning and code requirements.
And I think it's so interesting that Boulder and Colorado Springs went on opposite direction. I mean, Colorado Springs basically, restricted it from anywhere within the city by saying 1 mile. And so local jurisdictions can do anything, in terms of change. Although in the state of Oregon, they did not allow them to change it at all, or decrease the distance at all. So here we are.
Great, thank you, thank you. I just want to say, since I sit on the BOCC, this is going to be coming back to us. I'll be bringing back my regular report from the Board of Health. I'm really interested in hearing everybody's thoughts from the board members here. And I haven't formulated any of my own yet. I'm all ears. I just want to say this is something I hadn't contemplated until very recently, until we started seeing those letters. So very interested in hearing what you all say, and I'm sure the Board of Commissioners would be very interested as well. So if anybody want to begin, just Dr. Kurt, do you want to?
This is Dr. Giesel too. I'm online.
Oh, great. See you there. Hi.
I'd like
Hi.
to begin if that's okay.
Oh, I'll let you go in first. Since
Let her
you're
go
here.
first. Yeah.
Go ahead.
So I would just like to preface my comments by saying that we are the Board of Health. So we have been asked for our medical opinions on a topic that doesn't relate to business or zoning. It seems like things that, the Board of County Commissioners are going to have to weigh a little bit more heavily. So I would like to present my medical opinion on this topic. As Dr. Levin just pointed out, we are the second state to be doing this. There is not a lot of data. They cited a study in public comment, and that's really all we have. And compared to what we do in medicine and what things have to go through for FDA approval to prove that they're safe, we are nowhere close to understanding the implications of this medicine or this natural medicine. Also, people that are not used to prescribing substances are prescribing this. This is not being done by people that have been licensed to prescribe things in the past. And I think that is also a new and undeveloped world. Luckily, there seems to be a lot of safety data. There also seems to be few side effects. However, the side effects can be almost fatal sometimes and have long-term consequences and can, at times be medical emergencies. And I think that all of those need to be thought through as well as we have this conversation. Also, besides just diversion and besides just the effect on youth, I think it needs to be considered the equity piece that Kim put on that slide as well. What if people are trying to break in places to get substances? What happens to the neighborhood around there? Does petty crime increase? There's all sorts of different topics that need to be considered in this distance as well. And so I think that based on all those factors, I would urge caution. I don't see any rush to be the second municipality to make more permissive rules. We already have a permissive community. We don't have a large population. There's about 5,000 up there. I don't know how many treatment facilities we really need in our community. I think, again, in medicine, we are taught that you start with the least invasive and the least harmful modalities, which is talk therapy. And it seems like that is, when we're talking about the mental health services we still need a lot of that. And this is something down the road from that. So that's those are my thoughts on this. And I would be very in favor of a stronger regulation and a stronger 500 to 1,000 foot recommendation.
Thank you, Dr. Giesel. I'm going to go to Dr. Kurt next.
I'd like to comment and first state that I've been involved with the psychedelic issues as an interest because I attended the first two Aspen psychedelic conferences at the Wheeler and then investigated that further with going into what the licensing requirements are for the natural medicine healers. And I got Rick Dart from the Rocky Mountain Poison and Drug Center involved in a review of this. So we presented this as a topic in 2023 at the Montreal meeting of the North American Congress of Clinical Toxicology. And following that, I also have attended a 2-day conference that the American College of Medical Toxicology did in Denver a year ago, September, on this topic. And in that, at least 6 faculty members from the University of Colorado Medical Center in psychology and psychiatry described studies that they were performing at the campus in Aurora, which is, I think, within 1,000 feet of people on Colfax. So that it brings up practical problems, and I'm sympathetic with Andrea, who's a pre-existing licensed counselor who has gone beyond this and become licensed as a natural medicine healer, as I understand it. And so she has a pre-existing practice. And this also can apply to pre-existing premises that add to their liquor license requirements, because there's a kind of a pre-existing situation that we have in Andrea's situation. In addition, I'd like to point out that natural medicine healers treat people under the age of 21. So treating children is not an issue, and they are treating people with a psychedelic substance as part of the treatment. They are not necessarily selling a product like a liquor store. And we have liquor stores in the airport business center. We have facilities that are selling alcohol in other circumstances. And there's a 500-foot rule there. Is that really being enforced? So I'd like to go over the practical issues that we're facing here, because I'm sympathetic to the practitioners, and I'm also sympathetic to the community. So if we look at what is being advised, I suggest that we defer this immediately to the advisory board at DORA that oversees natural medicine healers. There's an advisory board that licenses DORA healers and was appointed by Governor Polis. So I advise we defer this question to the Natural Medicine Healer Advisory Oversight Board.
Thank you, Dr. Kurt. I appreciate it. That raises some questions, I'm sure. Linda.
I just, when listening to Dr. Levin, there's no correlation between, selling alcohol and selling tobacco to somebody who's doing therapy and seeing patients and using something in a therapeutic manner. That's, the medication is locked up, it's not available to anybody. I mean, there are lots of areas here in town where there's drugs that people could rob and increase your criminal activity, but I don't think that's what Ashley is presenting at all. And it's totally irrelevant that people are selling alcohol and cigarettes. It's totally different from what she's attempting to do. So I think it's great to seek further advice, but I don't think that the ability to sell alcohol at the airport business center and cigarettes and whatever, I mean, that's more dangerous than what she's attempting to do therapeutically. So it doesn't make sense to me that some of these rules and regulations that they have.
And can I
Thank
just,
you for that.
from everything I've read and learned, is that the psychedelics available in these healing centers are only available to those individuals aged 21 and over. So Dr. Kurt, I just want to make that statement so that everyone's working from that information.
Right.
Thank you.
Is that what you were referring to, Dr.?
I'd like to hear back from Krista once she's heard what I've advised, which is deferring it to.
I've got a question about that, but I don't think we can defer an advisory decision from this board to the commissioners. That's not going to hold any water. We might get a report or a testimony from them, but I don't believe we can defer a decision to them. Is that your understanding, Jordan?
No, I mean, this is how the law is set up, is that the state law is how it is, and local municipalities have the ability to,
Make a
to
referendum.
change it at the local
Mhm.
level. The Board of County Commissioners has asked the Board of Health to weigh in and give them a recommendation. Um, s- So
Okay,
that's
so
where
really, so we couldn't say, well, we're going to punt it to an advisory board of people we don't know.
And I don't
somewhere,
think-
appoint-
I don't think they give us any kind of recommendation. I mean, they are the advisories of license. They're not going to give a recommendation on a zoning thing, right? They're going to punt that themselves.
right.
Perhaps, yeah, okay. So
Uh,
nice
Greg,
try.
can you hear me?
I could, I heard, Krista, I heard you, if that's who was
Or
speaking.
it's Cecily.
Oh, hi, Cecily. I can't see you.
This
but
is
I
Cecily.
see you. Okay, hi.
Sorry, I can't, I'm not getting my camera to work. Apologies. But Jordana, I have a question, which you may or may not know, and this isn't entirely related to zoning, but I've been told that Denver, while I think that they're going by the state regulation for zoning distances from schools and daycares, they did actually increase the licenses needed in order to operate these centers. And I just wanted to bring that up, that strikes me as perhaps something that not necessarily today, but something that should be looked at in what would be of greater concern to me than perhaps the distance between. I don't know what a reasonable distance is from a place where children are, but I have bigger concerns about the license needed and the like education level needed in order to operate one of these facilities.
Thank you. Thanks, Cecily. I appreciate that.
I just too, Greg, this is Dr. Giesel again. I just wanted to make the point too, that like when we're discussing this, and I appreciate those comments, Cecily, like I don't think we should take this as a one-off. When we are making a recommendation to the Board of County Commissioners on this needs to be a recommendation as if this was going to be multiple people coming in front of us. It's not just about Ashley. Like this is not at all personal, in my opinion, about Ashley at all, in fact. Like we need to think about this globally for our community, and we support the public, right? We need to figure out what our medical decision on this topic is that best support the public. Thank you.
Thank you. That does bring up the point that I wanted to ask Jordana, is that, we do set precedent here. If we grant one permit for one thing, then you can expect others to expect the same treatment. So we do have we try to go for consistent policy among our policies. I don't know what to anticipate. I never expected, I didn't expect this to come forward, but I remember when the marijuana licenses came forward, there was a flood. I don't know if that would happen here or not. But the basic point that Krista makes is that if we do it for one case, we have to do it for every case. And are we prepared to make that recommendation? So there's a bit more to it than just one case. Also, this isn't for a new business. This is for a business that's existing in a certain location. But I'm just wondering if there's a distinction between new businesses versus, or it's a new activity in an existing location. Is there
The new psilocybin center.
a new
And I think all of these laws apply to new centers.
to new centers? Okay, I guess that's how it's
That's my
defined.
understanding.
Okay, Linda.
Ashley, could you explain your credentials again to us?
You'd have to come up to the microphone if you want it. And I'm gonna have to, we're gonna look at the clock here. I'm gonna want to
Be
finish
very
this in a
quick.
few, but thank you.
I don't like speaking.
Yeah.
I have a master's in integral psychology. I have specialized training from Naropa University. It's a 200-hour certificate in psychedelic assisted psychotherapy. I have another 200-hour training certificate specific to psilocybin assisted therapy out of Jamaica. where I went to Jamaica to train. And I have another 55-hour certificate from a facility in Oregon called Intertrek, where all of these I practiced and worked with psilocybin legally.
Got it. Thank you. Thank you for that.
Helpful.
This is
Sam.
Liz. I have a comment.
Okay, we'll go to Sam and then to Liz. Go
Okay.
ahead, Sam.
Thank you. I would defer to the city of Boulder. I think it makes a lot of sense that this be restricted from middle, junior, and high schools, but I don't think it makes a lot of sense to restrict it from childcare centers when it's so discreet, out of sight, out of mind, and facilitated in a way that's so different than tobacco, marijuana, and alcohol. This seems a lot safer than that, at least from a childcare perspective. So I see very little harm in allowing this to be done in areas that are within childcare facilities. And then I also would point out too, as far as this community goes, we know where our schools are. We generally know where our childcare facilities are. The facility that Skippy was talking about, I remember reading in the paper, was either $3,000 a session or $3,000 for a set of sessions. I don't know. It didn't describe that. But either way, pretty cost prohibitive. And if Ashley wants to share, I don't know the answer. I feel like having something at the ABC probably makes more sense for someone who is cost prohibitive from this type of treatment. It is in our community, whether we want it or not, unless we want to make it super restrictive. So why not allow it in places that really do no harm or do no harm as far as we know to the areas around it. It's unfortunate that she's next to a child care facility, but it's not going to make a difference to that child care facility. So I don't see that or any other child care facility for that matter. So I don't see why we would be so restrictive. I think the city of Boulder has it more or less correct.
Right. Thanks, Sam. Appreciate it.
Can I pipe
Comments
in one more time
online?
up?
Oops, I'm sorry. Liz is up next. Who is that? Was that you, Liz?
No, but I'll just speak. I agree with Sam and Linda. I think the alcohol, tobacco, marijuana examples of current distance restrictions are kind of irrelevant. It's not really comparing apples to apples. And I think Ashley's unfortunately in the crossfires with this current regulation. But as we've pointed out, there will be others in other locations that this will apply to. But I also want to go back to an early slide in the presentation about all the different elements, if you will, of this business that include not just the healing centers, but the manufacturing, and there were a couple of others that I can't recall. But
The state regs.
I don't know where those other things take place. The healing centers, I think, Sam's right. I think there's very little impact for childcare centers. So yeah, thank you. That was cultivation facilities, product manufacturer, and testing facilities. So I don't know anything about where that happens or what that impact would be. And I don't know who can answer that for us.
Right, thank you. I think that the impression I get is that the reason we're talking about the comparison with state tobacco and alcohol regulations is I think they drew on that when they drew this up for one reason or another. So we didn't come up with that. That's coming from state policy, right? Okay, just wanted to. Okay, so thank you, Liz. And Susan, you've had your hand up. Thanks for being patient.
Oh, sure. I just have a question about whether this apply, like our signage regulations would apply to this business and what those would be, like how prominent the signs can be, if it's similar to the marijuana signage regulations, if that is something else that has to be discussed in the future.
In these natural medicine rules, there are, I read them, and there were restrictions around what could be advertised. I think there's a limited amount that can be advertised within the office. And then I can't recall what it was that could be advertised in an outward facing manner, but that there is some more information in those rules. I can, bring that back to the board at a later date.
I mean, I'm in the interest of time, it seems that I get the impression that we have some pretty strong opinions on both sides of this and varying opinions. And I'd be intrigued to hear what, and how Denver dealt with it. But Cecily had suggested that, is there new information from what Denver's up to?
Understanding is that Denver kept 1,000 feet.
So Denver just kept it at 1,000. Do you see any need to come back with more information for this board? Or I don't know what our time frame is. I don't think we're in a hurry, but I don't want to rush it, and I also don't want to delay it. But if you think we need to gather more information and understand this better for any reason, I'd love to hear your recommendation.
The BOCC has specifically asked for a recommendation from the health perspective related merely to the distance. So I don't think that we need any additional information to give them a recommendation on that. If there's a desire to come back with more information, as this progresses and different jurisdictions pass different requirements for licensing or other pieces, we can continue to bring that back. But I think that the request from the BOCC was very, very specific.
Okay, then, well, then I think what we should do is look for a motion. Somebody would like to make a motion on how we would approach this. We could craft it very quickly and vote on it. And do we need just a majority vote? Thank you for that. If somebody would like to make a motion on how we would approach this, please go ahead.
I'll try. I'll make a motion that the Pitkin County Board of Health recommends the City of Boulder approach, which is at least 500 feet from any middle, junior, high school, but everything else be allowed.
Is that?
And if someone wants to amend my motion to
Right.
make it more palatable, please do so.
Sam, to Liz's point, I'm not sure if that applies only to healing centers or to all natural medicine businesses.
So I can make it specific to healing centers. Okay, specific to healing centers. That works for anyone.
And does it include childcare?
No, see that the point is it doesn't include childcare, only middle, junior, high school.
So for all other facilities apart from healing centers, it would maintain the 1,000 feet.
Yeah.
Just out of interest, how far is our Health and Human Services and the hospital from the schools across Meadowood? What is the actual distance? Do we have any of a sense of that? Has anyone ever discussed that? Is it
Measure in
1,000
Google
feet?
Maps if you want.
Could probably pull it up and see. Just wondering, because it seems like if medical care could all be concentrated, it might be a good thing.
About 2,600.
Okay, so it's
Do you think
beyond
there
that
would be
half a mile.
concern with marijuana facilities wanting to do the same locally if they see that we pass, if this is passed locally and changed?
I don't know.
Be like a little of a domino effect.
I don't think they're considered a healing or therapeutic practice. Marijuana subject.
Depends on who you talk to.
It's a totally different thing.
Totally different, the same type of, well, it's different in terms of that, but same
Yeah.
type of zoning
Oh,
conversation
zoning.
because marijuana
I think that
is
it
1,000
applies-
feet from schools.
Yeah, but it applies to access, and this is so different. It's not access,
Yeah.
it's therapeutic. It's different.
I have a question, Jordana.
Liz.
So do you think we can carve out that the healing center away from the manufacturing and those things? Can we specifically carve that out locally? Or does it have to apply to all of those things that are included?
That's a great question. I think that could be our recommendation, Liz. I don't know, in talking with the Pitkin County administration, I think I recognize that we're not experts in county code or zoning or this law in particular. And so they said just to come to them with the recommendation based from a health perspective.
Distance, that's
Well,
all you can
distance,
do.
and I think the health perspective is saying that the healing, wanting to call out the healing centers because it's probably going to be even more, it is more regulated, according to this board, than potentially a manufacturing facility or a growing operation where the board sees a difference in the therapeutic value of making that the therapeutic value of a healing center, and wanting to call that out as a distinct kind of facility that this change in distance would apply to.
Dr. Kurt and then Kim, Dr. Levin.
I second Sam Rose's motion,
Thank you.
and I would like to point out something that you mentioned. First, do no harm. And that's a oath that you take as a physician, prima non nocere. First, do no harm. And the person that I see being harmed here is Andrea,
Actually,
not the daycare center that wrote a letter that was distributed in support of her and saw no threat to the children in the daycare center. So let's first do no harm to Andrea. And I second Sam Rose's motion.
Thank you for that, Dr. Kurt.
I would like you to consider in this, making the change, the only change in it, instead of decreasing it to 500 feet and simulating Boulder, is to retain the 1,000 foot and just simply, take out daycare child. So out of the definition,
I accept that friendly amendment.
create a culture or a like we would be
Yeah.
putting it out to the rest of Colorado. We're still abiding by Colorado laws. This in this one case, just a healing center and just daycare / childcare center. We're taking it, we are taking it out of that definition, but maintaining the rest of it. So it's less confusing that way.
So her suggestion has been accepted by the motion. Would you second that? Do we have your second stands for that?
There you go.
Any other comment?
Consistent with
It's
that.
consistent with state.
Oregon, which does not, the definition, which they have the same, 1,000 foot school buffer zone, does not include daycare or preschool.
Yeah.
Unless, and I would suggest that we do this as well, unless that daycare or preschool is within a school.
Right, I
So
saw that.
if
earlier.
that's located within a school ground, then it doesn't apply.
The school trumps.
The school.
Yeah.
Yeah.
I don't think that would be an issue because obviously the childcare is probably next to the middle school. That's gonna make
It just needs to be
happen
followed
anyway.
in policy.
That's
all.
fine.
Yeah.
Accept it again. But is there
Um,
clarifications needed?
Okay, so the second is accepted on it sounds like we're evolving this.
I call for the question.
I want to see if there's any other further comment. I have we're still open for comment before I call the question. Does anyone else have, I don't see hands up or don't hear people yelling online, so I'm going to call the question. All in favor?
Aye.
Aye.
We've got 3 ayes. Opposed? That was an aye. That's an
Aye.
aye from.
Aye.
Aye.
We have, Susan, was that
Yeah.
that's an aye. I'm not sure if Krista's still with us.
Krista's an aye. I oppose this amendment. I oppose this resolution.
So you're opposing, so you'd be a nay.
A nay,
in that case.
correct.
Thank you. Okay. Cecily, are you an alternate or are you here?
I'm an alternate.
Oh, you're the alternate. Okay, for Susan. Okay, thank you. Right next to you. She has her picture up, so okay, I get it. Okay, then I think it passes.
Did you vote?
I'm going to abstain from this because I'm thinking I'm just going to try and chair the meeting and it's going to come to me again. So
So we had, the ayes were 1,
4-1.
3, okay. Making sure you all got those. We have Sam, Linda,
Liz,
Voting member.
Susan. Liz, did you have your hand up, Liz?
She did.
No, I'm just letting you know that I'm a yay.
Okay.
I would also suggest when you discuss this with the BOCC to discuss what was mentioned here in the conversation. with
Right.
Dr.
We'll have a
Ezel about-
transcript of that. Jordan, I think will come and present it to us. Is that correct?
Cool.
I'm expecting you to. And maybe Dr. Levin should come as well in that case. Thank you. Okay, I think we got today's business done. Is there any other further thing on this? I'd like to keep us moving. I don't see any suggestions. So thank you all for that. Thank you, Ashley. Director's update. I see I'm 20 minutes behind, but
That's okay.
talk fast.
We'll get there. So for the big update I just wanted to provide today, showed on the next slide, is around just some funding updates and changes that are happening. So with federal funding, we have seen some a loss in total federal funds that we've seen this year from what we've traditionally seen in the past of about $16,000. Maternal and child health, we expect this to come, so that isn't included in that dollar amount, but it has not yet been distributed. So that has been a delay in funding, hopefully not a decrease. We've seen our public health emergency preparedness funding decrease by 25%. A radon grant, all of the federal funds that we received through that were lost and didn't come through this year. So what we did receive was just state funding from the radon grant program. And then our federal immunization funds, we have not yet received, but we expect to receive only 90% of what we have received last year. So just getting everyone ready. We're inputting our budgets right now. That budget conversation will come to the board in October. And know that we are expecting to see a decrease in those federal funds. We also know that there's going to be some additional impacts and services to the community. So Medicaid coverage, cancer screening, family planning, sexual health programming. There was just a ruling the other day about an inability now for Title X clinics to serve undocumented individuals, as well as our healthcare coalition did not receive. They just received a stop work order due to federal funding that was pulled. So we also expect to see the potential impacts from the Supreme Court decision allowing federal layoffs in funds getting administered from the CDC, meaning that because those layoffs are going to stand, there's going to be a lot fewer workers to be able to be doing the work of actually administering and getting the funds out to the states, which then come down to us. So we can expect expect delays and more challenges in just even getting the money that has been designated to be flowing actually down to us at the local level.
Jordana, I'm sorry to interrupt, but can you be explicit in what Title X clinics do we have? Is that community health services? Like, what is that?
Yes, community health services.
Okay. Thank you.
And then, I think there's been an opinion that we didn't see potentially as many federal cuts in the funding that's detailed above because of kind of the nature and the timing of that funding when it was distributed, and that there's caution that additional federal cuts in the next fiscal year are completely possible. So I just wanted to provide the board the update that this is what we're moving forward with in terms of our budget for 2026. We expect, I know at the Greg is seeing this at the BOCC level, just the need in the community in all areas related to public health and access to care. We expect those to be increasing. And so we acknowledge that we're going to have to take a really comprehensive approach and look at what we're able to fund and where we're able to plug holes and recognize that there are going to be decreases in services that are going to hit our community as a result of what is happening at the federal level.
Thanks for that. I just wanted to say that the total loss of 16,223 in federal funds for the next fiscal year doesn't sound like much, but we haven't quantified everything else here, which is probably, I don't know if that's into seven figures or not for us, but it might be in terms of the impacts. And if you add that to the additional just health insurance costs for people. There's expecting an article today in the Colorado Sun said that Western Slope Grand Junction area is expecting 38% increases in healthcare costs for health insurance costs. So this actually adds up to millions of dollars. And I want to caution everybody, as I have on the other board, that every time if there's a gap, we know we can't fill all the gaps that come to us. So I don't want to create a race to get in front of the BOCC to ask for money to fill gaps, because we're just aware that across the board we're seeing funding gaps, but they're much more significant than what you have quantified here.
Agreed.
So, Dr. Levin.
On top of this, I just wanted to mention with Liz's question about someone's question about Title 10, is that community in Pitkin County, the way, as you all know, it's designed, community health services is a nonprofit, and it does provide the clinical arm of public health in our community. And so they are having their own significant cutbacks as well. And Title 10 is one of them, and it's the only one in the Valley that's Title 10 effect. So, but it's just one of many cutbacks that, as a nonprofit, Community Health Services is currently experiencing, independent as from the county. So it's hitting in different ways.
And so, sorry, this is Krista again. Has it already taken effect, like these rules? Like they're already feeling the funding cuts and they already
Supposedly July 1st, and I'd have
1st,
to
okay.
touch base with them, but that was, and still, everything's still in motion.
I mean, because again, like Kim, as you know best, this is going to be an uptick in the ER, right? And this is just going to like skyrocket medical costs. I just think that needs to be said as well.
I mean, in so many different ways, with Medicaid cutbacks and in so many ways.
Is there any way we could get a number, put a number on it? An estimate, a range, because it's so much more than what I see on the page here.
There's also 70,000 short in the CHS, Community Health Services.
Right.
So there's usually some surplus in the Health and Community Fund. If you take a look at that, you might, through the BOCC, be able to appropriate that from the surplus of
my guess
of the Health and Community Fund.
It will be fully used this year and ongoing.
So, as we get more and understand the impacts, this will be a continuing topic that will be brought back to the Board of Health.
Well, thank you for that.
No, thank you.
Director's update with Board of Health training.
All right. Well, I'd say get a snack, drink, if you want to. We'll settle in here for our annual Board of Health training. So if we click onto the next slide, you'll see that what's required is we are required as a Board of Health to do a yearly training. This year it includes 3 different sections, an introduction, a section on governance and oversight, as well as a section on emergency management. Past trainings are available on CoTrain for any board member who might be new and wants to go and do all of the past trainings. But they change these trainings every year and update them. So some of this material may seem a little familiar and some will be new. And that's part of the design, recognizing that board members are shifting and changing the makeup of boards over time. With that, I'm going to share my screen, and Nancy is gonna allow me to play this welcome and introduction from Matt Jackson at the Office of Planning and Partnerships, the state. Make sure my volume should be on. Okay. Let's see if this works. Nancy, can you turn your volume off?
Hi, I'm Matt Jackson, Interim Director of the Office of Public Health Practice.
Nope.
Turn on your speaker and microphone on.
Oh, yeah.
On your laptop.
Okay. But then we can't hear him.
Oh. The audio should come through without a clean microphone.
Okay. Are you able to mute that? You turn off the speaker? Okay. We did test this earlier. That's okay. I'll keep rolling us through here.
I'm not hearing that.
Yeah, nobody is. Can you lip sync what he's saying?
Okay. I will stop sharing here and we'll roll back to the PowerPoint, and if we can get this working, we will. And I'm still sharing my screen, it looks like. Even though we tested it.
So this needs to be pointed directly down there. And then we're gonna turn it on. Ooh.
We're gonna watch this. We can just test this.
I'm hearing. Okay, maybe I'm hearing audio come from this, so that's what's a little strange to me.
We need to bring it up on a different laptop. Personally.
No, it shouldn't matter. But what we can do, Jordana, if you step outside of the room, then you won't get all of the
Okay.
feedback. I can go do that for you real quickly if you want. Share.
All right,
And you
we'll
can-
do it when we get to the next
Okay.
section.
Okay.
Okay, thank you.
Yeah.
All right, well, Matt Jackson says welcome in that lovely video. Yep. Apologies. Okay. If we can go back, Nancy, to the PowerPoint. And I will walk through the overview slides. Great.
Out of interest, does this training have to be completed at any particular time other than just this year?
This year.
We really got caught up, we could push it to the next meeting.
Yeah. All right, apologies for that. We'll give this a go. So the six, the six functions of public health governance that the Board of Health is responsible for include partner engagement, oversight, legal authority, resource stewardship, continuous improvement, and policy development. And so I think we've shared, the board has had experience working on all six of these different areas, and the Board of Health training delves into different functions during different times. And this year we'll be diving into oversight. You go to the next slide. The other real basic understanding that the Board of Health needs to have are that we as a public health department are responsible for the following foundational public health services, as well as the foundational public health capabilities. So at the board level, always assuring at the policy level and we have the resources to be able to assure that these services are being provided in the community, including maternal, child, adolescent, and family health, environmental health, communicable disease investigation, prevention, and control, access to and linkage with care, as well as chronic disease, injury prevention, and behavioral health promotion. As far as the public health capabilities, these are all capabilities that we need to assure that we have the knowledge of how to do this work within our public health department. So assessment and planning, communications, policy development and support, partnerships, organizational competencies, emergency preparedness and response, as well as health equity and the social determinants of health. So this is a great slide. Sam knows this gets given to all our new Board of Health members. And you'll continue to see this throughout our work as we move forward. As we delve into this concept of oversight, you'll see that Colorado statute provides guidance for the makeup of boards of health, as well as their key functions and responsibilities. Boards may have functions and duties that include financial oversight, contributing to policy development, enforcing public health laws, and engaging partners. The most effective and impactful boards are those that work in partnership with the public health department leadership and the community. So by assuming responsibility for public health performance in the community, boards of health provide necessary leadership and guidance to support the public health agency in achieving measurable outcomes. This is achieved through three key oversight relationships. So the relationship with the executive director, that's me, a relationship with local public health department planning and evaluation, and the Board of Health structure. So those are the three different pieces that we're going to go through as I pull up this course online here. So Nancy, I will begin sharing in a moment. Okay. Okay. So this is the first piece that I think will be really helpful to talk through. The topic is steps board members can take to build and sustain strong relationships. So the first one is through professional development. So learning about public health and public health systems to better understand what's happening in your community and what the current department priorities are. The Community Health Improvement Plan can help provide the data and structure when making decisions about sunsetting old programs or onboarding new programs, for example. Another thing board members can do is ask questions. One way to learn more is to ask questions. You can always meet with me as the executive director to build understanding using the process for using data and making decisions, show curiosity and learn and understand how the public health system works. And I think by what you've all done today in the meeting, there's lots of great questions and comments that are happening with this board right now. And finally is open communication. So that candid dialogue and clear lines of communication are important steps to building and sustaining trusting relationships. Also, it's a culture of resolving conflicts by addressing issues as they arise. Lack of communication can lead to a lack of understanding. So just keeping everyone informed and in the loop is critical. We've taken some steps to increase communication among our board. The other piece here that will be reiterated is around the sunshine laws. So if 2 or more board members want a conversation with the executive director or other board members, the conversations must be held at a publicly noticed meeting. I'm going to go and share these, and then I'll open it up to some discussion here. So as far as steps the executive director can take to build and sustain strong relationships around sharing information is to build trust and maintain a strong relationship between myself and the board, is for everyone to share facts with candor and regularity. Creating opportunities for brainstorming, problem solving, and out-of-the-box thinking can help counter the uncertainties intrinsic with running a health department. The second is transparency. So communication, collaboration, and clear lines of responsibility. There are many tools available. We use a lot of them, but this training also helps provide additional tools for consistent meeting structures, schedules, and minutes, and information sharing platforms. And the final recommendation here is for a strong professional relationship. Board members and the executive director need to be clear on their roles and avoid overlap or potential conflict. So they're just restating that the executive director supports governance by providing the board with the necessary data and information in order to show accountability and transparency in the decision-making process. So with those big pieces of oversight and recommendations, I just wanted to open it up for discussion to see for those who've been on the board for a while or those that are new, what do you think that this board does well? Are there any areas that we can improve? Are there any examples that you can give of how we do some of these pieces?
Comments, questions? I was going to say the thing that popped up for me just now was remembering that this board does have transparency rules about creating a quorum. And if there's a quorum, it has to be noticed as if it becomes a public meeting. And that's just a good thing to remember as a BOCC member and as a members of other boards. That's front and center, but I'd kind of forgotten that Board of Health, had the same requirements. So if everyone gets together and starts talking about work, that's a no-no unless it's been noticed and public are invited to attend. And there are rules about noticing as well. I don't know if it's 24 hours or 72.
24 for an emergency meeting and 3 days for a regular meeting.
Okay, thank you. Any other questions on this? Linda?
I appreciate Dr. Kurt's sharing information to the board and hope you continue to do so. And anybody else that is able to share something that's relevant.
Mhm.
So thank you.
Yeah. I'd love to hear more reporting from CHS, which is doing, the functions of maternal child health, vaccination, and chronic disease. Having that kind of reporting and so that come forth so the community could hear it would be great.
Great suggestion.
So having the director come and give.
I can't hear you.
Having the director come and give reports, is that what you mean for community health services? I didn't understand.
You'd have to designate a person to do that. Mhm. You could.
And Logan comes, we usually have her come at least once a year to
Yeah.
share with the board.
Right. So I was just curious what Dr. Kurt's comment was, more often than once a year?
Yeah.
Can we go back and look at the exactly what the job is, the Board of Health, just very quickly on your is it defining oversight? Is that what the page, or just one category back? So regarding financial oversight, so to me, that seems like we would need to definitely see more thorough financial information when it comes, I guess, if we're providing oversight. And regarding policy development, what to our earlier conversation today, I think is right there. And I think we had a pretty robust conversation, and I think everyone who had something to share was heard. So that seems good. I realize I'm always looking for more information. I guess my fallback is always want to learn more. I don't know. I don't really know. On that note, just going back to that conversation, I don't really know what a healing center means, and it seems like it is our job to understand that. And so, but before we have on that topic, I think I'll just want to understand more and learn more before it comes to the BOCC. And the BOCC should have that information as well. And I think it's probably incumbent upon us to ask for it or prepare it. Does that make sense? Yeah. Since I know the definitions of all the new, natural medicine, what does it mean? What healing center, what does that imply? It feels like I want to make sure we all understand that. Maybe I'm the only one who doesn't, and that's okay, since I'm not a medical professional. Like Sam and I are maybe the only ones who aren't, unless you're an EMT probably. Yeah, okay. So yeah, I'm all by myself. Anyway, that was if I ever have feelings of insecurity being the only non-medical person in the room, that's okay. That's all right. But I just want to make sure we're all comfortable with what, how things are defined. So if anyone has questions about it, and I'll do my best to think of them when we're having the conversation. But here, and also I do appreciate Linda's comment. I really appreciate Dr. Kurt. I appreciate Dr. Levin's reports. And if there's anyone else we should be hearing from, let's ask them. Thank you.
All right. If there's no more comments, I can move on to the next section.
Let's keep going. Yeah, sorry. I don't want to slow you down there.
And talk through This is a great video. We'll see if it can play. If not, I will go in the outside room. Oh, nothing's playing. Okay.
Audio.
No.
Was this turned off?
Leave the room for us to watch this.
Can we turn this off?
Well, you'll get feedback if I don't.
That's fun.
Wait, try it now.
Well,
Oh, no,
these
that's
are our microphones, so it's how we're getting.
It's the whole thing
Mhm,
and not just hers. Okay.
You just play the video.
Okay, that'd be great.
Problem is, it's coming through your speaker. If that's the problem is, and your speakers, we won't be able to hear it still, right?
We will, like the people who talk on Zoom, you hear them because they talk into their computer, and so that's what the video should do.
Okay, go outside and try it.
I see.
Don't go too far.
Well, evidence that we tried it earlier and it worked.
Mm.
That's the problem. As
Okay,
soon as the,
can you all hear me?
We can.
we can hear you.
Okay, let me go ahead and share. Am I sharing my screen already?
Eric, you just need to push play.
Okay, just need to push play. Whoops, sorry, Jordana. Can you hear that?
Nope,
You can't. Shoot.
that didn't work. I think the system's become too complicated.
Okay, so sorry, I can bring it back in.
Okay, I'm gonna make a suggestion. Should we just punt and do this at the next meeting? Or do you want to keep trying? I want to keep us on somewhere close to schedule.
Saying that there's too much
Turn our
interference.
microphones off.
Could we all turn our microphones off? Would that help?
No one would hear you through Zoom.
If we're not talking that.
Turn hers on when she needs to. Or we could, whoever's talking could turn it back on, right?
It's up to you. It depends on.
Want to try it?
If enough people are here in the room that you feel comfortable doing that.
I think it's okay. You know, the great thing about this is I can give a brief overview here and just get us through at least this first section, Greg. Why don't I try to get us through oversight? We can do a little we can do a course evaluation, and then we can do like EPR in 15 minutes at our next meeting. So I'll try to be super efficient with everybody's time. CHAPS is a system, you've heard about it before. It's a Colorado Health Assessment and Planning System. This is how the state outlines that we do a community health assessment and improvement plan every 5 years. Every local public health agency in the state is required to do it. This is what helps us get a pulse on what the health impact, what the big health issues are for the community. And then we go through and develop a public health improvement plan. Our current priorities are around climate change and health, as well as access to care, including behavioral health. And Ariel helps lead that work. Our current plan goes through 2027, and we'll start doing another community health assessment in 2026. So all of that will come to you. But basically, this is just another, in addition to our core public health services, this is the result of that assessment, that improvement plan is another piece that helps guide all of our work. And so as a board, you help inform that, as well as you know that we can always go back to that to help give us guidance of where we should be focusing our time and effort. Board composition and term limits. The last piece is really just around the fact that boards of health are made up differently in Colorado. Board of Health functioning. Here we go. In Colorado, they can either be an appointed board, as this board is, or they can be just the county commissioners that serve as a board of health. So those are different. There's also district agencies that are multiple counties that come together and have a shared Board of Health. But I think just what's important to know about our board is that we have the required makeup, that we have a representative from the council, Pitkin County commissioners, we have a representative from Aspen City Council, a representative from Snowmass, and then we have 4 other at-large members that are appointed. And that is how we're made up. No business or professional group or government entity shall constitute a majority of the board. And we are certainly in compliance with that. So with that, I'll move us along to this knowledge check, Greg, and we'll see if y'all can answer these questions. We can do it together as a board. I'll fill in these details later. And then submit, and you all have completed this training site.
Is there multiple choice?
Yes, so what are the 3 key oversight relationships covered in this training? I'll give you a minute to read whether it's A, B, or C.
A.
All right,
If a vote for A there,
Yeah.
I think that's correct.
I guess that must be correct.
What are the 3 steps board members and the executive director can take to build and sustain strong relationships? So you get to pick 3 of these.
Oh, 3. Okay.
Share facts with candor and regularity. Yes. Avoid interacting as you're both very busy.
No.
Promote candid dialogue and clear lines of communication.
Yes.
Practice transparency.
Yes.
So we won't click, the working relationship should not involve brainstorming or problem solving. Some more really difficult questions here. True or false? All local public health agencies in Colorado are required to develop a community health assessment and a community health improvement plan every 5 years.
True.
That's correct.
True, correct. Open record sunshine laws require any state or local governmental body to discuss public business or to take formal action in meetings that are open to the public.
True.
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 Yeah.
And term limits and board makeup are the same across the state, regardless of the size of your county and how the board was formed.
False.
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 So
Yeah, because it could be the Board of Commissioners. We were the Board of Commissioners as the Board of Health previous to the formation of this.
exactly. Discussion questions. How does your board build and sustain a trusting relationship with your executive director?
Ski with them?
Meeting.
Snacks.
Okay.
Don't want to get anyone in trouble here. Are we okay? This isn't is this the actual form?
This is it. This is what's
Okay.
getting submitted.
Okay.
Describe your board's involvement with the community health assessment process. Anyone who's been around for one of these processes before, remember how we bring it to you?
Well, you bring it to us, yes.
You approve it, and then there's usually involvement in either the prioritization or the strategy, usually the help in the prioritization process, and then also in the approval process.
Everyone got that? There'll be another test after this.
And then how does your board assess the effectiveness of its work?
Public health.
Feedback.
Feedback from
Community.
the community?
Do a survey. Do a community survey.
Well, I think this is how do we do it? So we do have a community survey that goes out every couple years through the county that does ask about community's perception of services. And then I'd say we also bring to the board different metrics of how we're doing and how we're achieving the goals that we've set.
Awesome. Just
Try
to
to
report
interact that with Aspen Health, Aspen Valley Health now, which is becoming more of an established.
That the hospital gives feedback?
Yes. Because you talk to people over at the hospital or Aspen Valley Health, and they're not always aware of what's going on. There should be some cross-pollination.
That's in this community, it's hard to communicate. I have to say, it's amazing how people don't know what's going on, even though we have it. Sam knows this, you know, something really important happens and nobody's heard about it until you're making the rule, right? So communication's tough, and it's all the efforts are essential, and sometimes they help. What else have you got?
This is
we're
round around robin.
So any ideas we want to share, even though the test just said that we don't brainstorm. I always like to have ideas thrown out because somebody might have a burning issue regarding public health that they want to share with us. But if not, let's take up the time and keep going. But if you think of something in the next few minutes, raise your hand or yell. Hope I'm not being too
I have
informal.
something.
Liz has something.
I just
Great.
I was doing a little research on the side here about the new Title 10 restrictions. And then according to what I read, it took effect Monday, the 14th of July. Now, Linda and Kim can probably say more about this, but it makes me think that Community Health Services is scrambling right now, trying to figure out how to implement this new ruling. And it just breaks my heart. I don't even know what to say.
There's an article in the paper today. I haven't read it yet, but it's an extensive article about community health.
And it doesn't even touch on these new regulations. Unfortunately, Liz. Yeah, it was just ruled on July 10th. I didn't realize they gave them 4 days to put it into practice.
Mm-hmm.
So these are regulations not necessarily tied to the funding cuts, or maybe they are tied to funding cuts, but regulations about what you can and can't do, whether you have the funding or not.
Who you can serve.
You can serve.
Right.
Liz, I appreciate your comment. I'm currently the president of the board of Community Health Services, and it is a panicky scramble of most of the funding is through grants, and knowing that if it's going to survive, that has to shift, most likely to private donors, and in order for it to survive. And again, it is the clinical arm providing immunizations and clinical services of the public health's responsibility in the county. So it's very scary.
For Dr. Levin, the thing that would be important to me, and thanks for bringing it up, Liz, is to put a dollar figure on it, because we don't know what our shortfall is, and we don't know what we're going to try to raise through private funding. We don't even know where to start, or at least I don't. So to get a number associated with, where is the financial shortfall unrelated to the various regulations changes would be really helpful.
That, and I know Logan Hood can provide that. I don't want to say the wrong number,
Right.
But I know it's over 100,000.
Yeah.
Well, it's time to come share that with us.
Well, my
The thing is-
concern, I'm sorry.
Go ahead.
My concern is that no amount of money is going to help with this most recent ruling. It is dictating who they can see and who they can't. Although I do wonder though, if states can states fund the care, even though I don't know enough about it. to know what I'm talking about, but I don't know if states can go against that federal mandate that they cannot serve undocumented immigrants.
Thanks for that, Liz. It would be good to understand that. I don't know who could help us with that. Do we need a legal counsel, or do we need legislative counsel, or who do we need to tell us what's possible?
With all of these federal rulings that have been coming through, there are usually, because we're at the county level, right? This affects the entire country, all Title X clinics. So I think right now, there's going to be organizations wrestling with it at that level, and then to Liz's point, also at the state level, of understanding what that means, how it applies in Colorado, whether there's going to be any additional legal action to understand if that's a ruling that can actually be made. And just as we've seen in different areas, it may take a little bit of time to shake out, to Liz's point, to fully understand what that looks like, what the impact is, and if there's any degree of room to act differently, if that applies all throughout Colorado. And then if so, I would imagine it's going to be a real big question of what being a Title X clinic used to have so many benefits because of the support that was provided federally and the sliding fee scales and who you could serve. This greatly impacts how beneficial it probably is to be a Title X clinic. And Liz, you probably can speak to this more eloquently than me.
Is there an advocacy group for Title X clinics at this point, is it something the state attorney general's office would be working on, or is there a specific organization or nonprofit or group that's advocating in whatever form that we could hear from? I guess I don't want to feel helpless.
The organizations that receive Title X?
One who can work on behalf of them, right?
There is the National Family Planning and Reproductive Health Association that represents all Title X clinics in the country. I'm sure that they are working overtime right now.
Well, if it would be helpful, I just propose getting a report on what they're up to, what they're saying when something comes out. I don't know if you're in touch with that, but it could keep us in the loop. I think it's important that we know.
I do too.
Thank you for that.
Time-wise though, we won't meet again until October. Who knows what will happen between now and then? That's a long time, but yeah.
Always email it to us too. Okay, I'm gonna bring it back to does anyone else have anything else they want to bring up here? I want to leave us on a note that has action items involved. So if there's a way that we can learn more about these questions, it would be really, really helpful. And Liz, you and I can talk offline about that. We can try to find out, who can let us know what's happening at the federal level and the state level. Thank you. With that, I'm going to close the round robin, and our next meeting is on October 9th. But we can always communicate through Jordana before then. And I think I'd need a motion to adjourn if people are ready to go.
So moved.
A motion, a second from Linda. All in favor?
Aye.
All right. Thank you all. Thanks for the loose format of my meeting today. I appreciate you all.